Well, good afternoon, ladies and gentlemen. It's my pleasure to introduce pharmacist Dr. Ronald Kiguba, whose doctoral thesis was on pharmacovigilance in Uganda. Ronald is the only one of my PhD students whose viva voce I've been allowed to attend, because in Makerere University they adopted the system of the Karolinska in Sweden, where my late husband defended his thesis, and there is a public defence which supervisors are expected to attend. Ronald's youngest son, 3-year-old Jethro, was also in attendance, who asked his mama, "When is Daddy going to stop preaching?" And so, ladies and gentlemen, a very brief sermon on pharmacovigilance by Dr. Ronald Kiguba.
Thank you very much. Good afternoon, ladies and gentlemen. This afternoon, I will struggle with one of the comments my 3.5-year-old now son mentioned to me about 3 weeks ago. And he said, "Daddy, you never stop doing homework." This presentation focuses on the challenges and opportunities for pharmacovigilance in Uganda. And Sheila and I are representing a bigger team that is not able to attend with us here today. So, all of us have taken medications at one point or another and have experienced what we commonly refer to as side effects. Now, side effects can be good or bad, but the essence of a reporting system, which is the pharmacovigilance, is to focus especially on the adverse reactions. And so we define a suspected adverse drug reaction as any undesirable medical occurrence that develops after the administration of specified medication. A serious ADR is of interest to pharmacovigilance because it is one that is life-threatening. It requires initial or prolonged hospitalization and could result in disability or even death. A medication error is any mistake during the medication use cycle. So, what is pharmacovigilance? Essentially, it is a reporting system. A reporting system in this case with reference to the use of medications and the consequences thereof. And so it is a system that detects, analyzes, interprets, and then attempts to prevent ADRs and other drug-related problems. For instance, medication errors. A properly functional system should focus on ADRs, especially the serious ones, as well product quality, and like I mentioned, medication errors. Now, pharmacovigilance, in as much as it seems a lazy system and it relies a great deal on spontaneous reporting, largely by healthcare professionals, has in fact, over the past 60 years, led to the worldwide withdrawal of 462 medicines. Fewer withdrawals have been documented in Africa, largely because of its younger pharmacovigilance systems. However, counterfeit and substandard medicines have been withdrawn in Uganda, and this has been documented. And out of the many examples is a recent one where fake batches of an emergency pill were withdrawn from the market after being found to contain no active ingredient. So in study one, we set out to undertake a survey countrywide. My colleague has done a good job of explaining what Uganda is and the like. So we trekked this small country, north, south, all over. And we recruited 1,345 healthcare professionals from all levels of care, both in the public and the private sector. And we found that 1 in 5 healthcare professionals had recognized an ADR in the previous month, mostly aided by the suspect, the usual suspect, the patient. And so we also found that only 1 in 7 had reported an ADR to any pharmacovigilance body in the previous year, and only 1 in 50, a measly 2%, to the National Pharmacovigilance Center. So why is there lethargy? Why is there a state of apathy towards reporting to the National Pharmacovigilance Center? Well, a few reasons that were given was the scarcity of pharmacovigilance forms and the inadequate feedback from the NPC and other pharmacovigilance bodies. However, and in sharp contrast, for those who had suspected an ADR in the previous month, a good number of them, where over 46%, described the ADRs very well. And we think that this information, in as much as there is apathy towards the national reporting system, can actually be used locally within health facilities to solve local medication use problems. And we found that 106 serious ADRs were described, and if with the sample we had, if we could project this to the national level, or just from our study, we could find that 8 serious ADRs can be reported by 100 healthcare professionals every month. So, and there are some examples here of serious ADRs, which included Stevens-Johnson syndrome, a very rare and yet life-threatening skin condition. There were also cases of child fatalities and limb paralysis in children who were administered with quinine and antimalarial. There also was a report, one that actually was preceded by only 2 published at that time recently in the literature, the coughing up of blood or hemoptysis after the use of diclofenac. Coughing up of blood simply means that there's blood somewhere in the lungs. We well know that diclofenac causes gastrointestinal problems, but this was a case of involvement with the lungs. So we think that the pharmacovigilance system in our setting should encourage feedback. For instance, by providing reports of the analysis that has been done on from the information that has been submitted by reporters, and also by taking important policy actions, but informing the general public. Most importantly, and first and foremost, those who report. For instance, there was a case of post-injection paralysis, which I mentioned earlier, after quinine administration to children in eastern Uganda. And there was a team of surgeons who documented a series of cases, which they eventually published and released to the media. And after public outcry, the National Pharmacovigilance Center, together with the Ministry of Health, decided to change, because the paralysis was being caused by the inappropriate administration of quinine by unqualified nurses. And you know, in the buttock, deep down there is a very powerful nerve. And what happened in this case was that the nurses were injecting the drug straight into the nerve. And this was causing, in some instances, permanent limb paralysis. So they changed the administration site from the buttocks to the thigh. Now, like I mentioned earlier, healthcare professionals were guided by the patients based on the ADR complaints they had to then suspect ADRs. So we think that patients should be empowered to promote ADR recognition and reporting. And last on this point is, on this discussion is, we visited the MHRA and we found that, which was about, I think, last week, and we found that they run routine analysis. In fact, every week they run signal analysis to detect if there are any problems with medication use. We think that that can be adopted in our setting because in any case we receive a much smaller number of ADRs. All work and no play makes Jack a dull boy. I always wonder why they refer to Jack. Anyways, we took a break in the Easter holiday of 2014 and climbed the hills of Scotland. And Professor Dan did mention that there are so many childhood dreams, which oftentimes may not relate to the science. I still have a few dreams which I will present in another forum. In study 2, we enrolled 762 hospital patients. These were adults, and they were on the 3 medical wards and 1 gynecology ward. And this was at the National Referral Hospital, which my colleague described in detail. Now, we found that 39% of patients had used antibiotics immediately prior to their hospitalization, and 79% were prescribed antibiotics during hospital stay. These kind of figures are mostly found in the developing world. An exact mirror has been found in India and other countries in the tropics. Now, on the issue of suspected ADRs, we found that 1 in every 4 patients had experienced hospital-acquired ADR, and most of them were linked to antibiotics. On Annette's ward, it was largely misoprostol, which sometimes was a case of attempted abortion. Now, this slide is an attempt for us to show you in graphic detail how antibiotics were administered in the hospital. And here we take the example of ciprofloxacin, not because it is the most important drug, but I'll explain later the other examples that we looked at. Now, essentially, this illustration shows the first 10 days of antibiotic administration. And the rows represent, each row represents an individual patient. The red cells show that an individual missed all of their antibiotic doses that day. And the reason why I chose ciprofloxacin is that it is given twice a day. I could have used metronidazole, which is administered 3 times a day. And I can assure you, for the 3 most administered antibiotics, ciprofloxacin, ceftriaoxone, and metronidazole, the risk of missing all of their day 1 doses was 1/3. I'll take the illustration further. Imagine a patient with a serious bacterial infection, for instance, bacterial meningitis, who has been prescribed an antibiotic, but then who goes on to miss their first day of treatment. What are the chances that they will be incapacitated or even die? So this is a very serious issue for antibiotics, and we found that, we postulate, not postulate, but it's a known fact that missing antibiotic treatment risks treatment failure and breeds antibiotic resistance. Now, we think that the system weaknesses probably stemmed from the miscommunications between healthcare professionals and with the patients, possibly also understaffing and drug stockouts. Now, to this end, we have focused a great deal on the antibiotics, but now also looking at the ADRs, we find that, antibiotics, especially ceftriaoxone, which was the most frequently prescribed, was in fact the most implicated for ADRs, even after controlling for its high consumption and HIV status. And we are wondering, could the ADRs be linked to the quality of ceftriaxone generics on the market? That's a subject for further investigation. In our collaborations, we have so far published 3 papers with the National Pharmacovigilance staff, and at some point they thought they would merge the ADR form they have with the vaccine pharmacovigilance form. And the National Immunization Program, sort of with the NDA came together and developed a form. And then at some point, because we had made several contacts with them, they sent us that form and requested us to make our contributions. Now, we felt this was a huge opportunity. And we think that we still need to do more to ensure that our suggestions are taken up to drastically improve the quality of the data that will eventually be collected. We have also made contact with the National Pharmacovigilance Center, but specifically the Drug Quality Control Lab. And we are interested in them in a possible project to test the quality of the generics of ceftriaxone admitted into the country. I mentioned earlier that we paid a visit to the Medicines and Healthcare Products Regulatory Authority, and one key learning point was their adoption of a mobile phone app, which at that point when we interacted with them, they showed us figures that were double in number compared to the previous reliance on the paper form, which in many instances is not available. So we also plan to make contact with the NHS Greater Glasgow and Clyde and the University of Liverpool. So in our next steps, we have sort of initiated a meta-analysis platform for East Africa, where we hope that the tools that we developed and which we have now worked through to simplify could be implemented in other countries within the region to generate similar data so that we could then analyze the metadata to probably provide insight into the extent of the probably successes or challenges with pharmacovigilance in the East African region. We have so far identified 2 collaborators, one from Kenya and another from Tanzania. We also would like to promote analysis of Uganda's pharmacovigilance data, like I mentioned earlier. So to this end, we have done quite a bit of work in adult hospital patients, and we would now like to pilot a study in hospitalized children to investigate this missed day 1 problem for antibiotics and the extent of ADRs in this population. And last but not least, to investigate the quality of ceftriaxone in Uganda. The work that we propose to do in the short run, we think will generate preliminary data which can then be used to implement large-scale studies in our setting. but funding bottlenecks are a major challenge. For instance, the 2 studies we've conducted have consumed a whopping £31,000, and well, we thank Thrive and Wellcome Trust, plus the other team of funders. Now, electronic databases are scarce in our setting, and yet we need Africa-specific studies to answer Africa-specific medication use problems. Now, an interesting issue here is that the use of mobile phones is prevalent, and we think that the use of the mobile phone app for yellow card reporting, as was introduced in the UK last year, could actually be a welcome project in our setting, and it could probably improve pharmacovigilance in our setting. There's a growing interest in the field of pharmacovigilance in our setting, and we hope that this could improve research and practice. I'd like to thank my mentors, Professors Sheila, who has been very instrumental, very energetic, and sometimes I have stolen a bit of her energy to get by. I'd also like to thank the other mentors, Charles Karamaji and Paul Wako, also professors. Thrive and Wellcome Trust have played a key role here, and the African Population and Health Research Center, among other funders. This partnership has yielded 7 publications, and we postulate that more are actually on the way. This was the visit we made to the MHRA. And ladies and gentlemen, at this point in time, please allow me to invite back Professor Sheila to conclude this presentation. And please take my advice to answer all the difficult questions. Thank you.
I think as a biostatistician, if I have one message, it's if you design a data collection form, whether it's an app or anything else, it is not useful unless you have also designed the analysis routine into which those data feed, and from which you derive the information, the analyses. So a form without the analysis routines is a waste of everybody's time. Design the analysis when you design your data collection form. Thank you.